an incredibly soft voice. Am I hard for anyone to hear right now? Everybody hear me? Okay.
Yeah.
So we're going to get started. Unfortunately, I can't control my slides, so I may end up speaking from the back. So we'll see how it goes. So today I'm going to be talking about mobile health, the different applications you can use, the success and potential of it, and kind of proving the potential of it through data, lots of data. My slide deck is extremely full, so towards the end, if I feel like I'm running out of time and wanting to get you guys to food, I'll just start skipping things. So if you have questions later or you want to follow up with me, feel free to. So the things I'm going to go over is Text for Baby, which is an example of mobile health that we're using here at the center. We're coordinating and evaluating it here in San Diego. And then along with that is a flu module that's included with it, which is an interactive service that's linked to Text for Baby. And then I'll go more on the broad implications of what you can do with mobile health and how to make it successful and innovative for communities of color and communities in general. Next slide. So to start, this is hopefully where I'm going to end up when I finish it, is the fact that mobile health has the ability to reach diverse populations, regardless of their access to the internet, because we also have cell phones and text messaging, and also the ability to reach more diverse communities. Latinos and Blacks, as you'll see in the data, have higher usage rates, both of texting and internet use, and then the youth, which eventually will also be the elderly, and they're using it. And so it's also an ongoing sustainable resource. Along with location enabled, as smartphone continues to be picked up, other things that we can start doing with mobile health or ideas that we can have with it is actually have it so that resources and services and healthcare is being directly linked to the person using their phone and accessing it. And then again, the tailored information, the ability to actually tailor health-specific content to culture, to language, to chronic diseases, conditions. So we can skip. So currently there's 322 million cell phones in the US, which is pretty enormous. 88% of adults are currently using cell phones. And within those, 99% of text messages are read. I'm sure most likely everyone in here reads every text message they get. And usually within 3 minutes or less. And again, it's changing a little bit. And they're personal. So they're constantly with us. As the other slide said, 19 hours a day we're connected to them. And as studies are beginning to show us, people are sleeping with their cell phone on, next to their bed on their pillow. So taking a look at the demographics of internet use, and this is why I'm going to be shifting a bit of the presentation to focus more on text messaging, because with internet use, while there's the potential for it in the future, what we're looking at right now is there continues to be gaps. So higher income levels are using more internet than lower income levels, and along with age obviously, younger ages, like with everything, a lot more savvy with technology and able to use it. And then if we look over here, native-born Latinos are less likely, at only 51% are using the internet and have access to internet, whereas 80% or 85% are actually using their cell phone and able to text. So again, 322 million mobile phones. That's more mobile phones than we have people in the US. Next slide. The volume of text messages that are sent, we have over 2 trillion that were sent in 2010, and this is obviously increasing. I couldn't find the data that was more recent on it, but the volume of text is enormous. Text per day, on average, US adult is texting, sending at least 40 text messages a day. By age, of course, it's obviously a lot higher. I would say it's like an epidemic over here, 109 for the younger people a day on average with text messages, which is enormous. So we might actually have to come up with a texting intervention to get them to text less. But of course it's increasing, and we'll also see the increase over time as well. Next slide. So again, calling to texting, people are more likely to text. It's a lot easier, it's a lot more convenient. I think everyone in my family will send me a text because I won't answer their calls. Maybe I'll call them back, we'll see. Texting by race, again, we see higher rates among African Americans and Latinos in comparison to other ethnic groups. And looking at different meta-cogs, of course, we're looking at health and health abilities. So this is a little bit older in that it's Veterans Healthcare and Medicare. But we look at Medicaid, Medi-Cal, those populations are texting significantly more than other health insurance types. Next slide. And then smartphones. And this is something, there's a potential for smartphones. Of course, there's still a gap. So 50% of all phones currently being used, yes, as of February 2012, are smartphones. So that potential to leverage that will be considerable in the future. And then again, we're seeing with the use of smartphones that individuals who are younger are more likely to use smartphones regardless of income. So even with lower incomes, if you're in the younger categories, you're more likely to start getting a smartphone and using it. And along with that, in the lower income levels, your smartphones are everything. It's your computer, it's your access to the internet, if you're able to have that access. So I'll get into a little bit of the types of interventions that have been done thus far. There isn't a lot. This is a new, up-and-coming, very innovative way of managing health, managing chronic conditions that individuals are having, and for the most part, they're falling within these different categories. These people right here, behavior change interventions developed by mobile phones, did a short lit review looking at various interventions that are being used. And what they did find is 13 out of 14 showed proof of positive behavior change, a successful health intervention, and the fact that the interactivity and the tailored text messages created something that participants actually wanted to use and were receptive to. Next slide. So I'll get into Text for Baby. Does everyone in here know what Text for Baby is or have an idea? No? Okay. We're going to have to skip some of the flu then. So Text for Baby is the first national free-to-end user. So every single text message is free. Regardless of carrier, regardless of texting plan, these text messages are free. They send 3 a week, and it's based off of your trimester, so what stage you are in your pregnancy, and then the developmental stage of your child. So it goes up until 1 year of age. And what these services are able to do is to be tailored, action-based with resources, medical warning signs, vitamins you should be taking, and developmental cycles that the child should be in. Next slide. So here are some sample messages. They range from everything from healthcare access, immunizations, prenatal care, exercise, resources. So along with each of every one of these messages, probably 1 out of every 3 per week is providing them with a resource. We have over 800 partners. It's a national service. It was started by Healthy Mothers, Healthy Babies Coalition and Voxiva, who's the technology developer. And coalitions and coalitions across the nation. And along with it, I'll start discussing what we did in our coalition. Next slide. So we currently have, nationally, 320,000 moms who are enrolled, and this is since February of 2010. In San Diego, we have 3,500, and we're trying to pick it up, get as many people as we can enrolled, and get the information out.
Excuse me, is that all languages? Or
It's just English and Spanish. So the process to go through that, thank you for bringing that up, is you would text baby or bebe to 511411. You put in your zip code, and then you put in your due date or the baby's birth date, depending on where you are. So it started with a conference that we actually helped put on with the California Border Health. And we brought the person who brought this technology and started developing it to that. And from that Border Health Conference presentation, we ended up with a coalition with stakeholders that are relevant to maternal and infant health across San Diego County, who have now come together. And next slide. And what we've done is we've customized it. So not only is it tailored already to their trimester or the due date, or excuse me, the birth date of the child, but we've also customized it. So rather than receiving a national number, who then cycles them down, maybe they talk to 8 different people to finally get to whatever resource it is that they were initially referred to, they're getting direct referral. So they just go straight to exactly where they're going. We obviously left in a few national numbers in case they move, and they should be aware that there are national resources. And what we also did was we looked to evaluate it. So the Alliance Healthcare Foundation and First Five of San Diego provided us with the funding to see how exactly it's affecting women. And this is the theoretical model that we use to try and determine how to evaluate something like this. Because it's a little bit gray area when we're talking about a supplemental program that's texting. So what we're looking at is when they're receiving these messages, are they receptive to them? Do they think they're credible? Are they valid? Are they reliable? Both on the medical side, but also in the way that the user is receiving them. Is it increasing their knowledge and their attitude? Do they feel, because of their knowledge and attitude and that increase in knowledge and attitude, that they're more effective, that they can manage their pregnancy better, that they can have a healthier pregnancy, that they can manage their infant's development better? And along with that, with behavior change, are they actually accessing prenatal care more now? Which is very difficult to tell. So we can look at historical data, but can we really say that this program did that? So those are a couple of things that got touched, a little bit difficult. And then along with that, are they actually getting to the clinic? Are they actually getting to their healthcare provider, to the appointments, getting the immunizations? And so what we ended up looking at was knowledge and behavior, satisfaction and utilization of prenatal services, and then the last bit was cultural and linguistic amongst the Spanish-speaking population. Since the Spanish is national, it's more generic, and so we wanted to be sure that it was actually fitting for the population we have here in San Diego County. So we started with key informant interviews that helped us actually frame the way that we were going to do a survey. We then surveyed a very small number, only 122, but it was 10% that we currently had at that time, so it was in November. And what we found was, it's actually not as young as we thought we were going to be reaching. It's around 27, give or take 6 years. And then parity, the actual question we asked was, including this pregnancy, how many children have you had? And so it's not just first-time moms, but it's also first and second-time moms, which is also a really interesting thing to find out. And that, they're, regardless of the, semi-older mean that we're looking at in the way of age, many of them are college graduates or high school graduates. And then we had it actually surprising on this end, the fact that there was, it's fairly even along the different incomes, though it is at least over 70% are below 40,000. And then we had 24% who are uninsured, 35% who use Medi-Cal. Frankly, it should be 100% who are insured because these are pregnant women. And we have so many resources here in California and San Diego to ensure that pregnant women are always insured. Next slide. So when we look at the ethnic breakdown of the survey, we found that 45% self-identified as Latino or Hispanic, 34% as white. When we controlled, because it's also Spanish and English, so we controlled for Spanish and English. And once we did that, it brought this number down a little bit, and it brought the white up just a little bit, and it actually ended up being almost perfect to our census demographic data, so it's showing the reach that this has. And so the more interesting things here of what is it actually doing? And what we found is that 63% said that it actually reminded them of an immunization that they or their child needed, or of an appointment that they or their child needed. And then along with that, 38% said they actually called a phone number. And then you'll also see here that there's a higher trend of significance for those who didn't have health insurance. They're more likely to call a resource or a phone number. Along with the medical issues, so within all of those messages, based off your trimester, it's telling you if you're feeling this or dealing with this or seeing this at this stage in your pregnancy, you need to go see a doctor immediately. So these are medical warning signs, which is the greatest success of the program. Because, for the most part, your doctor has 15 minutes to talk with you about said issue. To be able to go over the medical warning signs is very difficult and time-consuming. So 75% said that they actually learned something that they didn't previously know about a medical warning sign. And then along with that, it's increasing their connectivity and their interaction with their health providers, so they're actually talking to their doctors about the different things that are coming up. So even if it is bringing up feelings of, oh my gosh, is this happening to me? They're going back to their doctor, and they're not being referred out to other resources. They're bringing it back to their doctor. We had extremely high rates of satisfaction. So from 0 being, this is the worst service I've ever used, please stop texting me, to I absolutely love it. We ended up with 8.5, which is really high. And then I'll really quickly go over the cultural and linguistic appropriateness. So these are kind of some interesting things that we did find, and a little bit sad if you look at the stats. So it's showing that there definitely were words that they had no idea were being used. What we couldn't find out is if there are medical verbs or medical terms that they didn't know. So that would be the next phase of the evaluation, to look into that a little bit, delve into it deeper. And then 30% said that I was just straight up incorrect. They were just using maybe bad grammar or just like awkward terms, who knows. But regardless of that, 92% said it was still clear and understandable. So regardless of the fact that there's all of these mistakes throughout the messages, they still understood them, and they're rating it a lot higher than they are with the English. So as the evaluation indicates, it's improving adherence to some of the most important things during your pregnancy: appointments, immunization. It's improving access. It's facilitating interaction with healthcare providers, and it's increasing health knowledge. And so what you can take from that is the potential of mobile health. So this is one idea. Obviously, there's a lot of men in here, so you're like, what is this? Pregnancy. But we do have men who sign up for it and want to be synced with their partner's pregnancy and kind of more involved with it. But the ability to continue to use this for any chronic disease is something pretty incredible. So I'm going to really quickly go through this. Let me check my time. Oh, doing good. Talking fast. Okay, so what they ended up doing last October is they introduced an interactivity element to the service. And so they sent a broad survey to, it was probably around 200,000 women at the time, you can go to the next slide, to find out if they're obtaining flu shots or not. And if so, and if not, why? And so they asked them the question, 31% answered, and of those 31%, the majority of which answered within 2 hours. And there's the interactivity and the time-sensitive ability that texting has. And then 31% said no, 29% said yes, 40% already got it. So we just completely ignored the gray area people. Next slide. So of those who said no, they continued to ask another question. Next slide. I think it might give me the flu. Cost, I don't think it's safe, I don't need it, or other. And they're asked to ask these different questions. Oh, wait 1 second. So within those, if they said cost, then the service referred them to different resources, a general number that they could call to get low-cost immunizations. If they said, I don't think it's safe or it might give you the flu, they were referred to different information of, it won't give you the flu and it is safe. And those who said they didn't need it, they kind of left them alone to not continually harass them. But then going on to those who said yes, they said, do you want a reminder for it? 54% said yes. Of those who said yes, they then gave them different months that they could put in a date where they'd actually like to have a reminder for immunization. And they did, so it reached out to 178. And then within those, as you can see, California is way down at the end over here, are amongst the most receptive. So within California, we're extremely receptive to anything that's telling us, oh, we'll give you this reminder, or are you interested in immunization? So we're a pretty savvy state for the most part, and we're pretty in sync with using texting and using these different services and requesting it and being receptive to it. So the overall response rate obviously is extremely high. We had nearly 30% of those who were asked the question actually responded. And what this is showing us is that individuals are willing to get messages like this, and they're willing to actually be continually referred to other things. So it's showing the capability of not just a texting service for pregnant women, but for anything, and the receptivity that we're willing to have with texting, even though it's a very personal service that's all on our own personal phones. We can skip this one. So then the potential of mHealth, and this is where I wanted to end and kind of open it up for questions or discussion, is the fact that communities of color have the highest rate of texting. They're disproportionately affected by chronic health conditions, and that text messaging and mobile phones and mobile use, along with internet, has the ability to be transformative and to affect childhood obesity, diabetes, smoking cessation, maternal health, infant health, healthy weight. Any of these sort of projects or programs or using this technological database and this ability, it is beyond transformable, so we actually have to leverage the fact that we're all so connected to these phones and that it can improve our health. See you in the next slide. So I'd like to open it up for questions. Oh great, we're right on time. So that you can all get to have some food. Please.
Nice presentation on it,
Thank
thanks.
you.
A couple of questions for you. When it becomes interactive, does it cost the person to text back
It
the
doesn't.
response? Okay, great. And then, can they actually get appointment reminders from the doctors?
They can, but it'd have to be set up through the doctor.
So
So it's a little bit different. So it'd be doing a customer services like we did, which you have to pay for. But the value of that, having it so tailored, increases the receptivity rate and actually, the behavior change. That's when it happens.
Okay. And then one last thing too. With the translation errors, like if you're Cuban or versus Mexican, you talk to Cubans, they say, oh no, we never say that. Terms like that. And then if we say it in Cuban Spanish, it's a swear word if they say it, that kind of stuff.
Yeah.
So I think that might be one of the things you were commenting on.
Yeah, it was something we were commenting. Less obviously on swear words because it's more general.
But it's part of our
Yeah,
part
so,
of our
yeah.
language, but they think it's a swear word and that kind of thing, even between Cuban and Puerto Rican.
Yeah, there's definitely a lot of hiccups with language when you're trying to transfer and just make it so general. Those are things that we're running into, but they did adapt them a lot to make them better and more succinct. So we'll see in the coming evaluation what happens.
Yeah, if I may add to this question, actually, the quality of the people is used to do the translations for this type of messaging and the design of the message is what really makes the difference.
Sure.
Most people, we've been testing for more than 6 months, like interpreters and translators. Even people that have worked in hospitals for 6-7 years, when we apply a standardized language assessments, they don't pass it at the approval rate that we require. So really the messaging is a matter of just the